Welcome you all to this session on ECMO transport. I am Dr. Dipanjan Chatterjee and I have no conflict of interest and nothing to disclose. Before I start on ECMO transportation, let us go to the back in history for the first ECMO transportation. It was by none other than Bob Bartlett's team, who did the first ECMO transportation in 1977. This was a 17-year-old girl with a Goodpasture syndrome with a pulmonary hemorrhage. And when the patient, even after ventilation, was not being having a proper gaseous exchange, Bob Bartlett's team was called in. They put in a VA ECMO in this patient and transported the patient back to his own center the next day with a large aircraft, with a military aircraft and large ambulance. You need to understand that at that time the ECMO equipments were very large and voluminous. So transporting this patient would have been a Herculean task. Before that, ECMO was being used, but not for any transportation. This was the first time that the transportation was done. After 4 days, the patient ECMO was weaned off and the lady survived. So why is it necessary to transport the patient on ECMO? Why can't we just transport the patient and to the ECMO center and put the patient on ECMO? It has been seen in various studies that these patients who need ECMO are very sick, and if they are not put on ECMO and they are transported, many of these patients would not survive this onslaught of transport and would die before they reach the ECMO center. So we need a safe mode of transport for these critically ill patients, and putting the patients on ECMO and then transporting increases the safety margin to a great extent. So that is why the hub and spoke model came into use, because ECMO center is usually a large volume center. Smaller centers usually they cannot do ECMO. They are not equipped to do ECMOs. So you have a large center, ECMO center, which caters to the smaller other nearby hospitals. And if their patients in one of these smaller hospitals needs ECMO, they refer these patients to the larger hospitals, from where ECMO team goes, puts the patient on ECMO and brings the patient back to the ECMO center. So ECMO transport can be either intra-facility, that is within hospital, or inter-hospital transport. In-hospital transport, do not undermine it, because it is where we learn the nitty-gritties of transporting these patients. There are various equipments that will be needed, not only the ECMO unit, you need the transport monitors, ventilators, syringe pumps, and a whole lot of other equipments. The patient may be needing to go to OT for a surgery, or can go to a radiological suite for a CT scan. In the CT console, you can see the patient goes in and out of the console quite a significant distance. So you need to have adequate length of tubing, otherwise there can be tug in the tubing. And even bed-to-bed transfer can be difficult unless you have a very coordinated team of physicians, nurses, and perfusionists taking care. Shifting of pediatric ECMO patients can be challenging, because very short segment of the cannula will be within the patient, and a gentle tug can displace the cannula. Coming to the inter-hospital transport, that is ECMO retrieval, it can be either primary, secondary, or tertiary. Primary is where you have the ECMO team from the ECMO center going to the referring center, initiates ECMO on the patient there, stabilizes and brings the patient back to the ECMO center. What happens in secondary transport is that the referring center, the patient is already on ECMO, but this referring center may not be equipped to do a long-term ECMO, or they are not, the patient may be needing a VAD or a transplant, which is not available in the referring center. So the mobile ECMO team from the ECMO center goes to the referring center, assesses the stability of the patient, and brings the patient back to the ECMO center. Tertiary ECMO transport occurs where, when you have an ECMO center, but there is no ECMO beds available, that the capacity is full, but the mobile ECMO team is there. And if a nearby hospital refers a patient, this ECMO team can goes to the referring center, initiate the patient on ECMO, and after stabilizing, shift the patient to another ECMO center which has ECMO beds available. So there are three phases of ECMO transport. One is the pre-transport referral phase, where the time is of primary importance because the patient is sick and with every passing minute can become more sicker. So once you get a refer, you need to reach the patient as soon as possible. Second is the ground time, when you are there, you as an ECMO team has reached to the referring hospital, assess the patient, take the consenting and initiate, stabilize the patient. And once the patient is stabilized, the patient is transported back to the ECMO center, and during this time, patient safety is of primary importance. According to the mode of transport, it can be classified as road transport by a ground ambulance, which approximately can cover at 300 to 400 kilometers at most in our Indian scenario, or you can have an air transport by a helicopter or a fixed wing aircraft. You can also have a hybrid transport where ambulance and helicopter, or ambulance and an aircraft can transport the patient. And also in larger centers, larger places, you can have a big aircraft into which the ambulance can go in. So then you do not need to move the patient in from the ambulance to the aircraft and then back again into the ambulance. So the sequence of transport begins when the reference center, the physician, he sees that the patient is not improving and going downhill. He talks to the relatives and then refers the patient to the nearby ECMO center. There, the ECMO physicians, the ECMO team discusses the case, and if they decide to take the patient in, they will talk to the relatives, take their consent for transporting, and refer the patient to the hospital admin. Because the hospital admin will have to do the financial counseling and also arrange for the modalities of the modalities and logistics of transport, and give the go ahead with the ECMO team for the transportation. In the meanwhile, there has to be continuous communication between the ECMO center and the referring hospital, because there will be need for blood or other equipments at the bedside of the patient during ECMO initiation. So the composition of the mobile ECMO unit can be depending on the center protocol or the patient requirement. It can be a combination of either an ECMO intensivist or cardiac surgeon, either of whom should be able to cannulate independently, a perfusionist, a nurse, an ECMO physician assistant, or a technician and transport staff. A combination of any of these should be there. Coming to the planning and preparation, the planning of ECMO transport begins much ahead of the call, that is the referral that you get. Because once you have the ECMO unit going, you will see that various other nearby hospitals will be willing to transport the patient under your care. So you need to have proper planning and preparation long ahead before you start the transportation program itself. So you need some equipment such as smaller ECMO machines, or trolleys can be modified to carry all the equipment together, or some centers even have large ECMO ambulances. But most of us usually do not have either of them. So we have to do with our own equipments and our own ambulances. But be sure that your ambulance is safe enough, has enough plug points and enough drugs and oxygen, so that you can safely transport the patient back to your hospital. The personnel need to be trained and about the ECMO machine, and with various simulation programs, the what are the scenarios that can occur during transportation, that has to be replicated so that they can equip to do ECMO and face any challenges during the transportation. And also the admin and logistics have to be in sync with the ECMO team so that you can overcome all adverse challenges. Coming to the road transport is the commonest mode of transport nowadays. And before you go for a road transport, you need to have a mobile ECMO equipment checklist. We have our own ECMO transport chart, and we usually carry almost all the things that will be needed for initiation and maintenance of ECMO along with us, because we are going to a different center where the equipment or the things that you will be getting you are not familiar with, or you will know many times we don't get many of the things. So we always carry almost all the things that will be needed for the ECMO initiation and transportation. So all things has to be taken. You take multiple sizes of cannula and more than one cannula of the commonest size that you usually use. We also carry an extra ECMO circuit, because if the patient is having a problem with the circuit, you can change over the circuit during the transport. We usually take a ECMO transport stand. This we have modified ourselves as this. It helps to keep the equipment along with the leg end of the patient. Carry enough oxygen, and do not forget that if you are having a centrimag unit, carry the backup console also. If you are carrying a Mackie unit, carry the hand crank. You carry all the drugs that will be needed for an emergency. This is a card that we have prepared. We usually carry this in two ambulances, one for the patient and the other for the equipments. And there will be adequate oxygen supply. We have to reach the patient at the earliest, either by the ambulance, or we carry our equipment in a different vehicle and the ambulances can come later. We go assess the patient, see what are the lines present, and do the consenting, see the echocardiography, and go for cannulation of the patient by the senior people, because there should not be any problem during cannulation of this patient in a remote location. And if there is any problem, then it will be very difficult to transport the patient soon. Like you do the ECMO, initiate ECMO in your place, you will do the same things there also. You ascertain the cannula position by an X-ray or an echocardiography, see the maximal flows, you optimize the ventilations, medications, etc., and stabilize the patient. Once you are sure that there is no bleeding or hematoma at the cannulation site, you call for the ECMO ambulance transport staff to the bedside and shift the patient to the ambulance. You can see that there is lot of clutter at the leg end, because we are keeping both the patient as well as the ECMO equipment in the same trolley. So there will be lot of clutter. There should not be any kink, and all your controls should be visible, so that if there is any problem, then you can address it. If the lifts are not functioning or you have a different egress, then it is difficult to shift the patient back into the ambulance. For the ambulance shifting, you need to have two oxygen sources, one for ventilation and the other will be connected to our membrane oxygenator. So before commencing the return journey, you have to ensure that the patient is hemodynamically stable and there is adequate supply of medications and all emergency drugs have to be kept loaded. You need to have double the expected requirement of oxygen, because there can be untoward incidences where you get delayed during the transport and you should not be stranded in the road with lack of oxygen. And we usually carry 1 or 2 units of blood along with the patient. Before commencing journey, you have to secure the patient and equipment, because there can be movement of the patient or the equipment can fall down, and ensure that there is no equipment is left behind. During the transport, you monitor the patients as routinely you do in the ICU, and also monitor the ECMO flow and the tubing color. Once within the back into your own hospital, you shift the patient back to the hospital bed, you can see that there is a coordinated movement amongst the staff as well as the ECMO perfusionists, so that there is no pull or tug in the lines. There is during transport there is movement relative to the surroundings and movement along with the surroundings, like the patient is within the ambulance and the ambulance is moving, and relative to the surrounding is like when you are coming in or out of the of your ambulance, you are on a stretcher, then there can be tug or pull on the lines if they are dangling outside. So you need to see that all your ECMO lines or the central lines or your earlier the perfusion equipments, they are in proper position. So in during road transport there is transport of patient from referring hospital to the ECMO center, and the movement of patient from the hospital bed to the ECMO stretcher and back from ECMO stretcher, a ambulance stretcher, to the hospital bed. So there is entry and exit of the patient. Those and those situations there can be problems. Coming to the air transport, we almost carry the same things that we do for road transport and also in the during the air transport, but there it has to be compactly packed, because carrying it in air transport is difficult because you will not be getting lot of space, and also the number of personnel are very limited to carry this equipment. There are multiple points where the patient is moving while the patient is going for an air transport. Like from referring hospital, the patient goes to the nearest airport by an ambulance, and from there the patient is shifted to the air ambulance, goes to the destination airport, and then from the airport again to the ECMO center. So there are a lot of movement relative to the surroundings. What are the changes that take place during the air transport? The peculiarities of air transport being, even in the pressurized aircrafts, the air atmospheric pressure will be lower, and if you have either a pneumothorax or something air-filled spaces where the air can expand due to the lower atmospheric pressure and cause compression on the mediastinum. So this has to be checked before you leave the hospital with an X-ray, and if there is a pneumothorax, it has to be addressed and put in a drain and keep the drain open, so that there will be no compression of the lungs during the transport. Also, the tracheal tubes, the air in the cuffs that can expand, and you have to check the pressure in them. The partial pressure of oxygen will be lower because of lower atmospheric pressure, so the membrane lung, in the membrane lung there will be less gaseous exchange and the oxygen saturation can come down. You need to go up on the flows at that time. The temperature can be lower. If you are not being able to connect the patient to a hemotherm, then you have to cover the tubings with insulation so that there is no loss of temperature. There may be noise, particularly in helicopters where you need to have hearing protection, and due to this you may miss out on the alarms, and the patients can have vibration or movement of the patient and equipment during the acceleration and deceleration. All those things have to be taken care of. There is a very crampy, the air ambulances are very crampy space, and you need to see that all your equipments, the controls are facing you, so that if there is any problem you can go for remedial measures. There is reduced ambient light within the aircrafts, and also you need to keep the membrane oxygenator or the pump at the patient's level, so that because of the reduced airway air partial pressure of air, there you within the blood there can be phasing out of of oxygen into the gaseous phase, and air embolism can occur. That is, the air can go into the your either pump or your uh, membrane oxygenator, and there can be an air embolism. To prevent that, all these equipments are kept at the level of the patient. The transport of COVID patients was difficult. In the first phase, it was first the fear of the of the transport staff, and later on, after in the second phase, we got the isopods wherein we could transport the patients on aircrafts. In the first phase, it was very difficult to transport the patients on aircrafts because it's a closed space, and if you do not have proper barrier, it is definitely going to infect the transport staff. You need to know the specifications of aircraft before you go for the transport, because what is the type of aircraft, what is the ingress or egress that is there, because many aircrafts have a very small door and ingress and egress is very difficult. Some aircrafts may be having a larger door, but it is difficult to get hold of one of these during your transport. What are the power connections available, what are the equipments within the aircraft, and how much is the oxygen that you are carrying in the aircraft, that is all has to be checked before you go for transporting the patient on the aircraft. And lighting on the plane has to be adequate. Post transport, once the patient has come back to the ECMO center, you have to brief the relatives about that the patient, how the patient behaved during the transport, and you need to do a team debriefing wherein you discuss what are the problems during the transport, so that there is room for improvement. You can do a better planning for the next transportation. Be prepared for disasters. The very common is that you can see that the flow going down because of kinking, or there can be discharging of the ECMO console. So we faced it in one of our transports where we had to shift a patient approximately 300 kilometers. After the initiation, uneventful initiation would put the patient on the ambulance. After going 50 kilometers, the ECMO machine had a power failure. We immediately changed over to a hand crank, but hand cranking over to for 5 or 6 hours is not safe for the patient. Fortunately, we had a Centrimag console and a Centrimag uh, pump head. So we changed over from this uh, Mackey equipment, that is a Mackey console, to the Centrimac console, and we could save the patient. So you have to be prepared for any eventuality. Why I gave the example is that you need to be prepared for any eventuality during the road transport, because on the road you are all alone. You are not in a hospital environment and you will not get any help. So you need to keep all your equipments, carry all the equipments that can save you in times of emergencies. You need to train the transportation staff, because on in the road transport, these staff will be the only persons who can help you out. Coming to the what are the complications that can occur, there is one of the case series from Stockholm came up with various events which can be related to either the patient or equipment or transport vehicle or human error or environment. These adverse events can also be classified according to the severity, like the category 1 problems, which have high risk of morbidity and mortality, where if you are not responding within seconds, like air in the circuit, or backup battery failure, or clot in the circuit or oxygenator, or the cannula dislodgement, etc., or the pump stops air. In the category 2, that is high risk of mortality and morbidity, but if there is no response within the minutes. So if there is any accidental extubation, the patient is having arrhythmias, patient is in bleeding, disconnection of oxygen supply, all these places you need to address it within the minutes. Category 3, there is need for attention, but there is no risk of morbidity and mortality, such as an aircraft technical problem or ambulance failure or ambulance accident that can occur, or delay due to bad weather, etc. Category 4, there is low risk, but the problems need to be noted, like airport delay, or the patient, there is a sudden change in destination. This is a typical situation where in air transport, the destination changes because of bad weather in your destination uh, place. Suppose then you have to go to a different place, take the patient to another hospital for the night, and then again transport the patient the next day. So how safe is the ECMO transport? In one of the articles that came up in 2021 with pre-COVID data, approximately 2,600 transfers were assessed, and there were only 4 deaths related to transportation. So mortality rate is only 0.15%. So there is transport on ECMO is very safe, and it is nowadays it is the primary transfer is commonest, and it is by ground transport. If you need to know further about ECMO transport, there is a very good article by ELSO in the ASIO journal. You can go through it. Coming to our last slide, what is our take home message? ECMO initiation and transport from a remote location is challenging, but it can be done safely by an experienced team. You need to have a proper planning, preparation, and anticipation of problems beforehand. And since you are initiating ECMO in a remote location, you need to carry all the equipments. And also, you are in an out of hospital environment for a significant amount of time. So, there be prepared to face unusual situations. It is ultimately teamwork that leads to a safe patient transport. Thank you.